Good evening. It's a real pleasure to gather with you, even if virtually. Thank you to all in the infectious diseases community for this wonderful recognition. Even more, thank you for your heroic efforts in understanding, treating, and preventing COVID-19. 2020, it's been quite a year. The Maxwell Finland Award recognizes an individual. As I've reflected on my 43 years working in public health, all major accomplishments and ongoing challenges require deep collaboration. I could happily spend my entire time thanking and reminiscing about the mentors, colleagues, and trainees I've had the honor and pleasure of working with. I hope all of you know how much your intellectual collaboration and your friendship has meant to me. But 2020 is not an ordinary year. So this year, I would like to hold up the public health systems we desperately need to maintain and strengthen. Protecting our nation's health isn't about Superman or Superwoman or supercomputer swooping in and single-handedly saving the day. This country must have the people, the systems, and yes, the government in place to protect the people. Let's go all the way back to 1977, when I arrived at the CDC. 1977 was the year that the US FDA licensed the first pneumococcal vaccine, a 14-valent polysaccharide recommended for use in those 65 years and older. The vaccine was licensed based on trials in South African gold miners, younger working adults who had a high risk of pneumococcal disease, living and working in the crowded setting of the gold mines. Limited trials in the US had been inconclusive. Further randomized trials were considered unethical given a licensed product. So the central question we needed to answer was, does the vaccine work in the US elderly? I started with a more manageable question. Of the over 90 serotypes of pneumococcus, what proportion of disease was potentially preventable by the 14 types included in the vaccine? And would that change over time as the vaccine was used? We needed a baseline immediately. CDC had two invaluable assets already in place. CDC's streptococcal laboratory was the national reference laboratory able to identify all 93 serotypes. And the National Nosocomial Infection Surveillance System collaborated with selected hospitals throughout the country. All agreed to collect and submit all isolates of invasive pneumococcus for typing. Then CDC started to get requests to serotype pneumococci isolated from individuals throughout the country who'd received the vaccine and subsequently developed invasive pneumococcal disease. Clinicians wanted to know if these cases should have been prevented. I distinctly remember the aha moment when it occurred to me that we could estimate quantitatively the effectiveness of the vaccine by comparing the distribution of serotypes in vaccinated individuals compared to the serotype distribution in the unvaccinated population. 1977 may sound impossibly distant. However, the elements that were essential in 1977 are still important today. CDC can answer questions that randomized controlled trials cannot answer. As pneumococcal conjugate vaccines became available and recommended for use in all US infants, we needed to know, how long does protection last? Are all serotypes in the vaccine equally effective? What unexpected findings or adverse events may emerge? Of interest, CDC was able to show that vaccinating infants also reduced disease due to the vaccine serotypes in the elderly. Overall, 65% decrease in invasive pneumococcal disease in the unvaccinated elderly. So what are these essential elements? CDC and partners need to have ongoing disease monitoring systems in place, including obtaining isolates. This means investments in population-based collaborations with state and local health departments and academics, with funding, agreements, technically expert staff, baseline data, and the ability for rapid response investigations. Today, we have CDC's Emerging Infections program covering a population of millions. Another essential element is dedicated scientific expertise. Epidemiologists, statisticians, laboratory scientists, informaticians, and we need the laboratory and computing capacity that these experts require. So bringing us back to 2020, we're all immersed in addressing the pandemic that we knew was coming. In January, we knew it was a coronavirus. We even had the sequence, but we had to make judgments based about epidemiology and preventive measures based on what we knew from studies of SARS and earlier coronaviruses. It has been truly remarkable what the molecular biologists and the vaccine development community have accomplished in less than a year. In the meantime, though, the country needed to know what to do to prevent the spread of the disease. CDC has had a long tradition of responding to unknowns. Distinct from many other institutions, CDC epidemiologists and laboratorians are committed to emergency response, to being pulled off ongoing projects and reassigned to epidemic investigation and response. When an unknown disease arrives, one has to make best guesses based on experience with similar diseases, but there's no substitute for rapidly studying what is actually happening. That's what the CDC is designed to do, to have the dedicated technical staff in epidemiology and laboratory science who can immediately work with partners. The results of those studies inform recommendations for action by expert advisory bodies. CDC then gets the results out immediately via the MMWR. I'm sure your inboxes have had more MMWR early release emails this year than ever before. As you know, it has been an exceedingly difficult year. A central tenet of pandemic response is having a trusted voice of scientifically based advice, consistently informing the public and the media accurately about what we know and what we are in the process of learning about effective prevention strategies. As you know, the CDC was blocked from playing that role, which it had played for pandemic flu and Ebola. But CDC did not stop investigating the pandemic in this country. They assigned over 1,000 employees to work with state and local health departments and academic partners to answer the critical questions and get critically relevant information out in real time. The need for real-time disease monitoring has also been highlighted. In this era of big data and astonishing progress in information technology, why were available data limited and sometimes delayed? Glitzy data displays and innumerable models were prominent, but have seriously limited utility when based on inadequate actual data. We need more attention to assuring real-time electronic messaging between clinical medicine, especially clinical laboratories, and public health data systems. Critical obstacles are proprietary systems that don't use accepted standards nor participate in public health information networks with appropriate oversight. Privacy of health information is important, but it can be addressed without preventing public health's ability to monitor the pandemic and get those data out to partners and the public. I'm as excited as you are about the reported efficacy results from the SARS-CoV-2 vaccine randomized controlled trials, which represent an extraordinary scientific and organizational accomplishment. Reflecting back on my pneumococcal experience, the challenge will assuredly not end with the licensure of the vaccines. Ongoing systematic evaluation of vaccine effectiveness and safety as the vaccines are used will be essential. The programs and technical expertise that CDC used to evaluate and guide pneumococcal vaccines over 43 years will be invaluable for this phase 4 monitoring. Public health, when it's working, is invisible. We don't have thousands of prevented cases walking the halls of Congress to lobby for their particular disease. Our disastrous failure over the past year is all too visible in the deaths and rapidly filling ICUs. I'd like to thank my colleagues at CDC and throughout the world for the wonderful privilege of working with you over the past 43 years. And to ask all of you, the National Foundation for Infectious Diseases, and my colleagues in the infectious disease community, to recognize the central importance of a strong local, state, and federal public health system with a nonpartisan, science-based, independent CDC. Unfortunately, this may not be the only pandemic we will face going forward. Dedicated funding for public health should be a national, indeed a global, security priority. Thank you all so much.